First one today, which we shall be hearing from a team from the University of Cape Town, South Africa, presenting on the PAC, uh, which is Practical Application to Care Kit. Uh, First, we have some housekeeping rule, which is that this meeting is being recorded. And secondly, if you're not speaking, please kindly mute yourself. You will have a session later after the presentation to have questions and answers, uh, as well as discussion. You're free to keep your video on if you wish to. And you can introduce yourself in the chat, maybe type your country and name so we know where you're coming from. I'm really excited about this session and looking forward to it. Before we start, I will kindly ask Penka to introduce our speaker for today.
Hi everyone, and welcome to today's session. So our two speakers for today are Ruth Koenig and Natira Bosch. They are all medical doctors and they work with the Knowledge Translation Unit at the University of Cape Town. I don't know if Ruth Koenig, do you want to go first and tell us a little bit more about what you do, the work you're doing around guidelines in South Africa?
Thanks, Penka. Thanks, Etienne. Hi. Well, we've prepared a talk, me and Natira. So I think that will help to explain what it is we're doing, if that's okay. Yeah.
Sure,
so we'll
sure.
jump into it.
Okay.
I'm very happy to take any questions, either as we go or at the end. However you see fit. Yeah. Okay.
All right, so I'll pass over to Etienne. Etienne, do you want to go ahead and start with the session?
Okay, thank you. We'll now give the floor to Ruth for the presentation. If you do have any question while they're presenting, please drop it in the chat or note it, as well as if we don't read it, you should indicate when we are having the question and answer session, then we can as well discuss it directly. Please, Ruth, have the floor.
Thank you. So as I explained, excuse me, I'm just going to make sure I'm sharing the right presentation here. I'm joined here by my colleague Natira Bosch, and we're going to take you through two sections to our presentation. The first is I'll describe the work of our unit and around PAC, the Practical Approach to Care Kit. And then Natira is going to talk a little bit more about the work that we've done more recently, utilizing AI in scanning and sourcing resources for clinical decision support. But let me jump in here. So we're based at the University of Cape Town in South Africa, and we're a knowledge translation unit that's been going for about 20 years now. I'm just going to minimize my screen so I don't watch myself talking. There we go. Sorry, just want to work out how to. There we go. And there's our team. We took this photograph last week at our end of year do, which is why it looks so colourful. We're usually reasonably cheerful. And there are about 35 of us now, a few people missing from the photograph. And we're divided up roughly into teams, although we all work together. And there are those of us who work developing clinical content, those who work on helping to implement that content and designing training and implementing training. We have a research team, a team focusing more on digital and tech innovation, a graphic design team, and then the leadership and support services that keep the unit running. There's a noise that sounds like a notification. I wonder if we can mute it. Thanks. So that's our team. And the work that we do as knowledge translation focuses more on the second type of knowledge translation, is aiming to try and get evidence and policy into practice and affecting health at a population level. And PAC, which is one of the main products of our unit that we've been working on to develop and implement over the last 20 years, comprises clinical guidance. We call it a clinical decision support tool, or the PAC guide. There's a training package that goes alongside it, and that's underpinned by health system strengthening and monitoring and evaluation components. And what I'm going to do now is kind of take you through each of these elements in a little bit more detail. But just to say that over the last 10, 15 years or so, we've been working with governments here in South Africa, but also in other countries, to implement PAC to support primary care reforms, because PAC focuses on supporting primary care delivery. So you can see that we've had PAC in some form or another in South Africa since 2001, and it's called nationally the Adult Primary Care Guide, and in Cape Town, the Western Cape Province, we call it PAC. We introduced it with the government in Botswana in 2013. It's been localized and implemented in Nigeria. We've had a long-standing partnership with the Municipal Department of Health in Florianopolis in Brazil. And you can see it's been updated several times since then. We worked with the Ethiopian Ministry of Health in 2017 and supported them to implement PAC around the country. And then most recently have worked with the Primary Care Directorate in the Ministry of Health in Indonesia to implement PAC. And they've embarked now on their rollout to over 10,000 primary care facilities. Yeah. So just to give you a little bit more detail about what PAC is as a guide, it aims to be a resource that covers the life course and speaks to all health workers working in a primary care environment. So PAC is used by doctors, but also by nurses, clinical officers, community health workers, anybody who's kind of at the front line of primary care can use PAC in some form or another. And you can see we've got versions for adults, which is the one I'll largely speak to today, the orange one, adolescents and children. And then, of course, we have tools designed to go along with those for community health workers and for patients themselves. And what PAC aims to do is to combine all latest policies into one resource that can be used as a tool in everyday clinical practice. I'm trying to get this toolbar out of the way. Anyway. And just for example, this is the PAC guide that was published in 2021 here in the Western Cape, and that combines over 1,700 clinical practice guideline pages that are policy and clinical guidance here in the Western Cape and South Africa into under 200 pages for use by nurses and doctors in primary care facilities. And so you'll probably be familiar with this knowledge pyramid, where we're focusing largely on the third generation of knowledge products, whereas you and your team are probably working more with primary studies and synthesized knowledge. We take outputs of that work and package it for easier use and into clinical decision support and algorithms and checklists. So to have a look quickly at PAC, it's a comprehensive tool. It aims to speak to the presentations of adult, child, or adolescent walking into a primary care facility. It's got over 500 symptoms, syndromes, diagnoses, and conditions in it. It's symptom-based, syndromic approach. It aims to be as integrated as possible so that a patient with multiple conditions is or multiple presentations can be managed at the same time. and the arrangement of the information is pretty standardized for ease of use. And these are 2 pages, kind of fairly typical kind of pages: a symptom page, approach to weight loss, and a page on hypertension is in the chronic conditions section of the guide. And these are all available on our website, and I'll share the link later on. So you can see there just an example of one of the content pages arranged in alphabetical order depending on the patient's presentation. And we've got over 40 symptom pages, and each one of those, and that's the second part of the contents page is the chronic conditions. And you can see that we've included there common chronic conditions, priority chronic conditions, and trying to speak to the need here when we developed it in South Africa, and what the clinical priorities were and what was prevalent here in South Africa. And that was validated actually by a symptom survey, or a survey of reasons for presentation that was conducted in conjunction with and led by Prof. Bob Mash at the University of Stellenbosch in 24,000 consultations across the country in primary care facilities. So an example of a symptom page, what we're aiming to do is to track the clinician's decision-making process. So the top of the page has got a red box to try and identify which patient needs urgent attention, and then prompts the screening for and diagnosis of common presentations and chronic conditions. And the algorithm will incorporate the history examination and tests, and even health education and management that is necessary for a symptom-based approach to diarrhea. And then just a few more details here. You'll see on this page, and the printed version doesn't tend to have this, but the electronic version does, in our global version of PAC, which I'll explain in a moment, has got numbered recommendations. So each one of the recommendations has a number. So that's another example of a symptom-based page. And then the chronic conditions section of the guide has also got a standardized format and tries to use the assess, advise, and treat approach. And that's really seems to help clinicians develop a structured approach to seeing their patients. And we've kind of color-coded the assess box into history, examination, and tests for ease of navigation. And then I wanted to show you this rather boring-looking page, but it appears at the front of every one of our guides and basically contains the names of all the contributors and reviewers to PAC's development. And so when we developed the clinical content 10, 15 years ago now, we worked off local policy, and where there were discrepancies in policy, we drew on the evidence. But then the next step in that process was to sit with clinical working groups of stakeholders and get their input to make sure that the content was easy to access and usable and actually practical. And it helped us really to thrash out and sort out very practical kind of issues around referral pathways, availability of medications and tests, and scope of practice of clinicians using the tool. And so the people that are listed over there are a mixture of policymakers and managers, and then nurses and doctors, pharmacists, and other allied health professionals. And also we've included representatives of patient advocacy groups to join those clinical working groups. And this has meant that that the content is as usable as it can be, because of the people who are going to be using it are involved in its production. But it's also helped to ensure a buy-in into its implementation and into its sustained implementation, because we'll get feedback from these people into the latest published version for the next edition. I think this is the most up-to-date one that we have, but here you can see the various iterations of PAC over the years, and we have worked in this province in the Western Cape to update PAC every year, and of course that's been necessary largely because of the churn of evidence and policy around HIV and TB. And yeah, PAC used to be blue, and it's kind of become orange, the adult version when we rebranded it, and then the purple version is the one for children, and the paler blue version is the one for adolescents or youth, and you'll see interspersed in there some versions for the other countries. And then what we did after we worked with the Botswana Ministry of Health, we realized that there was no point in our unit being the people to update the content all the time, and the aim was to work with local ministries of health and other stakeholders for them to adapt and localize the content for their own setting. But for that we needed a global version of PAC. And so what we did was we formed a partnership with the British Medical Journal and leveraged their evidence synthesis processes and evidence horizon scanning processes to create a global version of PAC that was aligned now to international evidence. And we also drew on WHO guidance so that the PAC global version now aligns to WHO Essential Medicines List, WHO clinical protocols, and the evidence that we've sourced through best practice. We tried briefly to source the evidence for each one of the 3,500 recommendations in PAC ourselves in a rigorous way, and that was just going to be overwhelming, and we would get PAC global. And so we've used this mechanism with the British Medical Journal. Hello? I'm sorry, I can't see anything. So if you need, or I can't see any of you. So if anybody needs to say something, then please go ahead. No? Can I continue? Right.
Yes.
So what happened? Yeah?
Go ahead, please.
Thank you. So what we did was we took each one of the recommendations and placed it into an evidence database. And it looks like my animated pictures are coming on backwards, so never mind. There's the fever page as an example from PAC Global, and as I mentioned, each one of the recommendations are numbered with a little black dot. That's the numbering. And then for each one of those recommendations, we checked what best practice had to say for that recommendation and what the World Health Organization had to say for that recommendation, and we populated our database with those references. And you can see here, for example, from the fever page, there's a recommendation number 2. I think that might be the next. Yeah, there we go. Recommendation number 2 speaks about managing shock. And here we have a recommendation from best practice and a recommendation from the World Health Organization that agrees with what we had in our Western Cape version of PAC. So now that's the PAC Global recommendation. Of course, we'd find instances where our PAC recommendation disagreed with that evidence from WHO or best practice, and then we'd either change the recommendation in PAC to align with WHO and best practice, or there were times where there'd be discrepancy with what best practice and our PAC Western Cape guide and what the WHO said, and then we'd have to work out how to resolve that, making sure that PAC always spoke to a lower resource setting context. So we weren't aiming to align everything in PAC to our high income country best practice evidence synthesis product, but wanting to make sure that we had as good an evidence base as possible for best practice or PAC Global. There were times where there was no evidence or very scanty evidence or nothing very robust, and often then we'd have a practical approach to a clinical decision, which we preferred to put in rather than not giving any recommendation at all. In the flow of this content, we couldn't kind of suddenly leave a little gap in the algorithm or in the checklist. And that would then have a note for the localizer in each country for them to adapt it to local resources and policy, etc. Yeah, so there's best practice and World Health Organization logos. Okay, so once we'd created that PAC Global version, we set up a system using that evidence database to try and maintain it. And so what we did was we implemented a weekly scan of the change reports from best practice, because as they were updating all their 1,500 monographs, we would get reports from them of anything that had changed, and we could check to see if any of our best practice references had been altered by the updates, and could implement them into PAC. And we also we chose priority topics, non-communicable diseases, communicable diseases, women's health, mental health, palliative care, etc. And we scanned WHO topics and the essential medicines lists for updates on a weekly basis. We also did a monthly scan of the IRIS WHO repository of their publications. And then we also did an ad hoc kind of check of PAC local guide updates. So as we were updating PAC Brazil, for example, or Brazil team were updating their PAC Brazil, or we were supporting government here to update the PAC Western Cape or the adult PAC guide, we might have refinements that come from those updates that would then feed back into PAC Global. And this included feedback from the end users. And so we managed to conduct updates. So we produced the first one in 2016, and then we managed to update PAC in 2017 and 2018. Had a bit of a break, and then in 2022 we worked with the Clinical Systems and Services Unit at the World Health Organization to update PAC for their WHO Academy primary care offering that they were developing called Impact. But of course the challenges to do this, and the reason for the gap apart from COVID, were the fact that we didn't have much funding to keep maintaining this. We don't have a very large team to be maintaining all the content, and we're very busy with our local updates and supporting other countries to update their content. So trying to maintain this global template has been very challenging. And then, of course, the volume of source documents is expanding all the time. And this photograph I'm showing you here is of Prof. Lara Farrell, who heads up our unit. She's standing next to the printed copies of all the source documents that we need to work our way through to update our South African adult primary care. And then the distraction we often had, as I mentioned now, is that our local PAC guide updates are time sensitive, largely because we're needing to publish them in time for new HIV policy, for example. And then that leaves little time for us to populate an evidence database of local guide updates. So the only database that we have of evidence sources for each one of the recommendations in PAC is for this global version. So those have been the challenges that we've met along the way, or some of them anyway. Okay, I'm going to move on now to just describe how we help to implement this. So a big part of our work is to ensure that this policy aligned and evidence-based resource is actually put into practice. And so you can see here a PAC training session going on. You can see it's pretty laid back and interactive, and they're basically looking at their guide. So there's no lectures, there's no PowerPoints. Everybody's looking at their guide. And so the curriculum is designed to try and introduce people to how the guide works and how to use it, and to use it in their everyday clinical practice, and to focus on priority clinical conditions and your health system strengthening initiatives. So it isn't aiming to teach the comprehensive content set of PAC to everybody who attends the training. It's aiming to focus on priorities, but at the same time, almost shifting the culture in a primary care facility to using PAC in everyday practice. And then the approach that we've used with training has obviously shifted over the years. but started out as using educational outreach, training, paper-based training, with all the staff in a facility sitting around and looking at their guides. And then we've also developed a curriculum that's available online, which people can do by themselves, but we find enjoy sitting together and actually working together through the clinical content and the curriculum. And that's a link to our school, which is also on our website, our online school. And there's the curriculum. So the curriculum is essentially the patients in the waiting room. And we create clinical cases that aim to speak to these clinical priorities, and also help to pick out the features of the PAC guide so that people become used to and comfortable with using it, but at the same time can become aware of the clinical priorities or the system strengthening initiatives that they're needing to implement in their everyday practice. And so over the years, we've developed a huge bank of cases that can then be adapted to Ministry of Health priorities, depending on what the focus is. And then these, of course, need to be updated to speak to the latest PAC guide. Okay, let me continue and I'll describe this now. So just to describe a little bit more about how it gets implemented, so just sort of covered the curriculum a little bit there, but the implementation approach is using a cascade training model. And this has helped us to support the scale up of PAC in South Africa and also in Ethiopia. And it's being implemented now in Brazil and Indonesia, where there's a cascade of PAC representatives who are already employed in government at the various levels of the health system that implement PAC. And so the training that you saw happens in the facility with the staff in teams, and they are trained by a PAC champion who usually works in that facility already and doesn't necessarily need training or lecturing support, but is the person who's going to champion everybody to use this tool. And then there's usually a cadre of master trainers at provincial level who both train up those champions and also maintain the program. Often as part of jobs to support primary care delivery. And the two photographs I'm showing you there, the one is on the left there is the Ideal Clinic Initiative, which has long been a policy here in South Africa to improve primary care delivery, and PAC forms a clinical component of that Ideal Clinic. And the paper on the right showing you there, we wrote with the Ministry of Health in Ethiopia to describe the scale up of PAC over a 5-year period and the factors that kind of supported that, and the factors that hindered that rollout. But now almost all of their primary care facilities have received PAC, and they've updated PAC several times, 3 times since its initial localization in 2016, 17. Yeah. So that's the training model. Yeah, and as I've mentioned, actually, the implementation aims to work with all players in the health system to ensure PAC's implementation. So I'm not going to speak much more to that slide. I mentioned earlier on that there's a health system strengthening component to PAC, and that really gets implemented in all steps of PAC's delivery. So in its localization, in convening those stakeholders to giving input into the content, in its training, in the implementation cascade. There are lots of opportunities to strengthen the health system along the way. When the reviewers and the localizers of PAC are interrogating local policy in order to update and maintain the PAC content, that provides opportunities to resolve inconsistencies between policies or gaps, and also to clarify and and grow scope of practice. So little funny picture you can see on the left-hand side, that kind of snapshot of an algorithm. It comes from the diarrhea page in PAC, but you can see the medications there. Our rehydration solution is orange, ciprofloxacin and loperamide are blue, and cotrimoxazole for ISIS-4 is green. And so what we've done there is color-coded each of the medications according to the caterer of staff that can prescribe them. And then the picture in the middle there is a picture that's used in the PrEP room, or the vitals room, the initial screening room, that helps to rationalize screening activities in a primary care facility, for example. And so by training the team all together, it also helps to coordinate care within a facility and clarify who's doing what. And then that review process of PAC, especially with all the various stakeholders involved, will help to clarify referral pathways as well. The other paper I'm showing you here now is one that we wrote with the municipality in Brazil, which uses PAC, which describes how the municipal primary health care department utilized PAC to respond to 8 infectious diseases outbreaks that occurred over, 5 infectious diseases outbreaks over an 8-year period. And they included COVID, obviously, Zika, Mpox, Leishmaniasis, and dengue fever. And PAC, because of the way its clinical content is arranged, symptom-based approach, was flexible enough for an update to incorporate those infections and prompt the recognition and diagnosis of those infections. And then the training approach with its interactive case-based approach was flexible enough to incorporate cases now around those infectious diseases as they became prevalent, and the culture of staff sitting together and talking about their cases using PAC lent itself to an outbreak response as well. So that's that paper describing how PAC supported both the ongoing delivery of primary care, but a response to the outbreak at the same time. And then, of course, part of the PAC implementation, and I've kind of alluded to this a little bit, is the localization package that we've over the years developed to support countries to localize PAC to their own settings. As I've described, the global version, which now, of course, is out of date and we need to update. The evidence and decision support that comes from that evidence database I described. There's a manual taking people through the localization and preparing them to either pilot or implement PAC. We've compiled medication and equipment test lists from PAC, which managers, pharmacists, and policymakers find very useful to get their facilities ready for PAC implementation. There's an implementation manual, and then, of course, training materials and the training program, which have evolved since the slide was put together. We've got quite a lot more then. Okay. Just a very brief word now about our research in the Knowledge Translation Unit. I'm just checking my watch and we're on time, and that I will do her part in a moment. So we're also a Health Systems Research Unit, and the focus of the work that we do is randomized controlled trials alongside PAC's implementation. And along with those trials, we often conduct process evaluations and economic evaluations. And we've completed 9 of these studies and have 2 underway, which I'll describe very briefly in a second. And you can see that these trials have occurred in both South Africa and in Brazil, involved thousands of patients, thousands of interviews, and I think we might be even close to 100 publications describing that work. And that's all available on our website as well, the publications. A very one-slide overview of our results of all that research. So with implementation science trials, the effects are not huge, but there have been effects, and they've been consistent across several of these studies, and they've covered a range of health outcomes and health behaviors and healthcare behaviors, including prescribing, appropriate referrals, case detection, You can see for TB, there were several studies that showed an improvement in TB case detection. Increased access to evidence-based treatments in the context of task sharing. We didn't show any effect in one study where we evaluated on depression case detection. But other health outcomes, especially in HIV, have been positive, as well as healthcare utilization patterns have changed, increasing primary care visits and less inpatient days. And some of the qualitative work that's occurred alongside these trials, I'm not doing justice at all, but have shown that the program highly valued by managers and clinicians. And then our most recent publication has shown that there's also been sustained impact of PAC. This was in Brazil, that showed ongoing effects on chronic respiratory care after its initial implementation. This is a study that wasn't conducted by us, so it was an independent, cost-effectiveness study that looked at comparing the integrated and comprehensive approach of PAC, which used to be called Primary Care 101, and that was compared with the WHO PEN program for NCDs, and it found that PAC proved more cost-effective. And then just briefly, two studies that we're currently busy with. The one is looking at trying to use PAC adolescent or PAC youth, which obviously focuses, again, it's a comprehensive tool, but focuses and emphasizes adolescent health issues, looking at trying to improve access for adolescents into primary care. So not only looking at the clinical content, but kind of the bigger picture of how we're actually going to get adolescents into healthcare. And we're working with primary care facilities, one of them you can see there, but also schools. And then the other study that's currently still underway is looking at drawing on PAC, and we worked it to be called Enhance, and that's focusing on multiple long-term conditions. And again, that's in the context of a much bigger study than just the clinical aspect of it, kind of looking at how we need to shift the health system, support health system shifts in order to improve the care of people with multiple long-term conditions. So this is the last slide, and I'm drawing on a quote from some of the qualitative work that we've done, but this essentially is the focus of what we're aiming to do here is to support the nurses and doctors and other health workers working at the front line in their everyday interactions with patients. And there's our website for you to learn more, but very happy to take questions. I'll look to you, Etienne, to see if we're going to stop for questions now, or rather move on to the Nathira's piece, and then we can have discussion.
Well, thank you so much. Thank you so much. I think we just move on straight to Nathira, and then we'll receive all the questions once in the discussion section. Thank you. So, Nathira, please, if you're ready, come on, please. Hello, Nathira.
Nathira, you're on mute. You want to unmute yourself? You need to select the share button, the screen share, or you could give me the presentation if it's available and I can share it. I'm afraid we're sitting in different offices, so I can't
Okay,
go.
yeah, thank you. I think while you're sorting that out, we just try to catch up on some of the questions, if that is all right.
Sure.
Yeah, I have a couple, but we'll start from the chat, I think. One was from Alvin. Alvin, do you want to ask that? Oh, let me just read it. Okay, Alvin asks, he appreciated your presentation. Thank you for this great presentation. I might have missed it along the line, but just how can we leverage these resources and training within Gene Africa? Yeah, he's just asking for ways that we can use this type of resources within Africa, actually, as a whole, I think, as we move forward. So, any thoughts on that, Ruth?
I guess I'd look to everybody here to answer that question. I mean, we work with units of health. We can hear you, Nathira.
Yes, thank you.
Should we go ahead with the questions, or should Nathira speak first?
She can speak as well. Yeah, let's go ahead. Is she presenting a slide or she's just speaking?
Yes. Can you share your slides, Nathira?
Yeah, then go ahead while she's sharing it. Maybe.
Yeah, and then let's answer, because I think part of what your question is there will be answered by Nathira to some degree, and it will be good for us.
All right. Yes, I think that makes sense. Then that's the more reason why the questions should come after the whole presentation.
Okay. And I'll look through it in the meantime as well. Thanks.
Nathira, are we doing okay? Making some progress? Sharing?
Hi, everyone. Thank you for your patience. Just a bit of technical issues. I am ready to present now.
Okay, then go ahead, please.
Okay. Screen share.
Beautiful.
All right. Okay. Good afternoon, everyone. I'm Nathira Bosch from the KTU. Thank you for the opportunity to speak. I'll just be chatting very briefly about how we can use AI for improved evidence scanning and guideline formulation. So as Ruth, discussed in her presentation, when it comes to guideline formulation, there's a vast array of knowledge that gets drawn on when a guideline is formulated. Millions of primary studies are produced each year, and publications, secondary data that are synthesized from that is close to 1,000 as well. And so when we look at the process of guideline formulation, there's a number of challenges that arise with having to source and interrogate those large volumes of information. Not only that, but it needs to be integrated into a local setting. So, any local policies or national, laws that govern how the healthcare system works. And in order to formulate, new guidelines or products or tools that can be used by healthcare workers, this entire process is quite time consuming. It's quite complex, and depending on where you are situated in the world, there might be a scarcity of skills when trying to translate knowledge in this way. And so here at the KTU, we looked and we asked ourselves, how can we innovate this space using new technology? And with AI, we are in the process of developing our AI-supported healthcare assistant, which we call Aisha. And Aisha basically uses, these new AI technologies, such as large language models and retrieval augmented generation, to interact with text and query the text and get responses in language that is easy to understand and use to formulate guidelines. So, as Ruth, so beautifully highlighted, with the PAC product or the PAC guideline, we have been able to localize, PAC for different settings in different countries. But we were looking to see, how can we streamline that process using the AI tools. So when you look at curating and interrogating the data, using AI, we are able to intelligently extract documents from existing repositories. We are able to assign labels and tags and then interrogate that data using everyday language. This also helps us in localizing the guidelines, because when we store all of the local policies and relevant guidelines in one database, you are able to interrogate not only a single document or a single guideline, but multiple documents, policies, and guidelines together in an attempt to streamline the evidence process or the guideline process. And once Aisha is in full effect, we are looking to source it as a sort of living guideline, where every time new information or new sources of information is being published in the global space, we can add that to Aisha and interrogate it in real time more efficiently. And so this is quite a dense slide, but what I'm hoping to highlight is that, clinical guidelines and their users, it's not a siloed space. Often healthcare workers need to interact with guidelines, but also with policies. At the same time, policymakers need to look at what is existing, what the existing literature, evidence, or policies are saying. And in the same sense, us as clinical editors, when we develop new guidelines, having to look at these different sources of information. And the ultimate goal of Aisha is to build up a repository that can link or serve as a link for these different stakeholders, so that there's not only benefit to the clinical editors when we develop our guidelines, but also direct access to healthcare workers in the future or policymakers when needing to do scoping exercises and finding, relevant information and guidelines, policies, and legislation in their local settings. So this is what Aisha looks like when you log on. And this is the, the dashboard. At the moment, the two main tools that we are able to utilize on Aisha is the evidence database and the clinical query function. In the evidence database, we're able to upload, documents as we find them available on websites or as they are published by national ministries of health. And we're able to interrogate that data source within Aisha. We currently have 2,000 documents, all of which are open source and mainly applicable to South Africa, but also to the Global South and lower middle income countries in general. And with that database of 2,000 documents, including policies and evidence sources, we have been able to use artificial intelligence to create summaries of each of the documents, to interrogate the documents by asking questions about the documents, and then using those answers to streamline how we as clinical editors create recommendations. So one example was looking at diabetes, and when you interact with Aisha or a large language model, you're able to ask it a question. And so we asked it, what are the target HbA1c levels for diabetes within South Africa? And within the International Diabetes Federation. And the large language model used in Aisha was able to generate an answer and gives you an evidence source of 10 documents from where it generated this answer. And what is most useful at the moment is that you're able to access those documents directly because they are stored in the database, and you can view the pages or you can download the original document so that you as a clinical editor or guideline creator can interrogate the data yourself. But it also, it assists you in knowing where to look and which documents to look up. As I said, it is a work in progress. It's one of our, things that we really are looking to expanding, who is able to use it and how we are able to use it. But the main opportunities that we are hoping to benefit from is that it will reduce time, the time required to create our guidelines, in that, that first pass of having to scope and curate all of the documents by a clinical editor won't be as time consuming. Once we have, it's going to be adaptable, because once we, identify a setting that we hope to apply Aisha in, for example, a different country or a different region, we can then upload the relevant documents within those settings, relevant policy documents in those settings, and then interrogate and ask, how does this differ from what was previously mentioned in a document or in a guideline? And the future potential here is, very vast, because as we all can see, AI is developing, and the potential uses for AI is developing at an exponential rate. And so as that technology is further refined, we can further refine the processes and the abilities of Aisha. But the important limitation is that we cannot overlook the importance of human oversight in eliminating the bias and the errors that the AI could produce. And then also in the way that you interact with the AI. If you're not able to ask it the right questions, you're not going to get the right outputs. And so as much as it has been able to streamline our processes, there's still an important skill required of having that human oversight and ensuring that the evidence and the process is followed correctly. Sorry. And so, opportunities for future scaling. We're really hoping to work towards a open access repository for low and middle income countries in the global south, looking to incorporate, existing, what existing databases have done and upscale that so that localization can be easier, and the costs and the time and the expertise needed can be minimized. But obviously, all of that is only possible with global partnerships and stakeholder, the relevant stakeholders. But going forward, we have a lot of hope and excitement that this will be something we can leverage for guideline reduction in the future. Okay, thank you.
Thank you so much, Aisha. Natira, thank you. Thank you. Your presentation on Aisha has carried me away until I forgot your name. No, that is really interesting. Thank you, Ruth, for this package for us. I'm really grateful for you sharing this repertoire of experience. This is all within Africa, and if we can tap into what we can produce, I think we can do more. And like Natira concluded, I think we need to do more of partnership. And one of the ways which Gene Africa is thinking of doing that is to actually provide this platform so that we are able to share. And by this, we are inviting anybody who is doing any great work within Africa in health to share with us what they're doing so we can learn and know what is going on, and we're able to collaborate effectively. Thank you so much. Patrick has a question. Yeah, you can unmute your mic and go ahead, Patrick, and ask a question.
Okay, thank you very much. Great presentation there from Ruth and Natira. And I think it's amazing that we have this actually ongoing on the continent, because it demonstrates what we can do, especially in aspects of AI and.
Sorry, we are having challenges hearing you, Patrick.
Okay, is it better now?
Yes, sound quality is really, yeah, I thought it was
okay.
maybe.
Is it? Yeah, I think I was a bit far. There's an echo.
Yes.
Okay. So let me.
I think if we go without a headphone, might be better. I don't know, but I think so.
Let me try. Okay. So.
Okay,
is it better now?
Yes.
Okay, so I was highlighting the fact that this is really impressive to see that we are doing this on the continent. I mean, it's challenging the global perspectives. The assumption is usually that these capacities are not available in Africa. However, these capacities are there, but because the excuse is always that these capacities are not there in Africa, funders tend to not speak to those who have these capacities in Africa. So this means that these capacities themselves may not grow or may not be seen at the global stage or may not be given the credence that they require. I was particularly really happy with the way that it was able to integrate the BMJ resources, the WHO IRIS resources, and how large language models are being used within the Aisha project. And this is very promising. And I think it's the kind of thing that we would like to keep contact and talk a little bit more about moving forward. I'll just be curious to also know how we can consider like health technology assessments within this program, because that's something that could also be very useful, especially for African interventions that may still be interventions that have been used in the North, but that we need to consider context within the assessments of these health technologies, the economics behind it, how culture comes in, how behavior and certain traditional norms also come into play. It's something that I will be happy to take up the discussion further. Thank you.
Good. Thank you, Patrick. Okay. Any other question before we go into the chat? Anyway, Ruth, maybe just answer that, react to that, and then we move to the next one, please.
Greetings, Patrick. Thanks for the feedback there. And yes, I'm really excited, as you said, Etienne, that this is an opportunity for us here in Africa to be sharing our experiences, and I'm keen to be hearing those of others and how we could collaborate further. I can't speak specifically to health technology assessment questions, but it would be very interesting to hear how what we have done and are still doing could be expanded further into other fields. Just to say that we do land up getting some funding for the research that we do from, you saw there that one of the studies NIHR funded, and we've got a development grant now from the NIHR to develop a research collaboration to start looking to developing a proposal for a study for a cross-country evaluation of PAC, and try and pull together all the learnings from the various countries that are starting to implement PAC. So that might be the beginnings of us getting a little bit more funding for some of the work that we are doing here in Africa. But yeah, the funding for the AI work that will hopefully help to make a lot more efficient our processes. Yeah, we're still seeking that as well. But keen to keep the conversation going. I don't know, Nathira, if you wanted to add anything.
No, I'm just working through some of the questions in the chat and replying to some of them.
Okay, thank you.
Okay, thank you so much. Okay, I just have one question as well from myself before we go to the chat for that discussion. At least based on your experience, you've actually have some great experience across Africa. You've worked in Botswana, Nigeria, Ethiopia, collaborating with these people. Have you any kind of feedback where this has become more sustainable, or you found it easier to implement or to have this project? And what are the characteristics that has made some of this really more better? At least you are in South Africa, so I can't, based in South Africa, knowing the context, it's likely to be more easier in doing that within your own context. But what about these other 4 countries, for instance? Have you any particular thing that you can share with us?
Thanks, Etienne. So we had MEPI funding. I'm sorry, I'm not sure where that's from. It was around health education, and that supported us to work with the NCD Directorate of the Ministry of Health in Botswana back in 2013 to localize PAC and support them to implement it. And when that funding ended, so did our relationship with the Botswana Ministry of Health. We worked in conjunction with the university, the family medicine department at the university. And so they work together with the ministry and apparently have updated PAC since, and I believe it is now known as the Botswana Primary Care Guidelines. But because the funding ran out, so did our relationship. And the same thing happened in Nigeria. In Nigeria, we didn't manage to establish a contractual relationship with the Ministry of Health, and I would say that was key for our work anyway, is to be establishing relationships with Ministry of Health and getting funding to do that work together, and that's been the best way to embed the program. And there we worked with Prof. Joseph Anna and his team at an NPO called HRI West Africa, and they were the ones who led the localization of PAC in conjunction with the Ministry of Health, and they implemented it as a pilot in several states in Nigeria for PAC Nigeria. And then because the ministry never took it on board and didn't have the funding to take it forward, PAC Nigeria hasn't progressed. Although it's being updated currently, Nathira, but with a private organization. So I'm telling you more the stories of how we haven't succeeded with this. Ethiopia has been an interesting experience because we, again, had some funding to support the introduction, localization, to build the capacity within the ministry to localize, maintain PAC, and implement it. And then when the funding ran out, we haven't been involved with it for 5 years, and it was only towards the end of last year that I got hold of the head of the primary care directorate to say, what's happened to PAC? And that was when we worked together to write that paper. So funding is a big problem.
Yeah, thank you for that, at least for highlighting that. I'm just wondering whether beyond the funding, or have you, in your experience, build any kind of strategy for this kind of collaboration to be more sustainable within Africa? Because it's challenging, because it's really, personally, it's very disappointing for me hearing that something which is very good works for 2 years or 3 years and is never sustainable. So I'm wondering how we can develop a kind of strategy where we kind of initiate innovations that we can actually sustain rather than building and breaking. Yeah.
No. I mean, PAC has sustained in Ethiopia. So that paper I showed there is the ministry have scaled it up, and they've updated it themselves 3 times, and they own it. It's working. It's just that our unit isn't involved with it in a formal, ongoing way. I'm hoping that this research collaboration that I told you we've now got NIHR development funding for, to pull together a research collaboration, will help to maintain our relationship and will help to grow this kind of PAC community and cross-country sharing. And that might be something that helps to sustain it longer term.
Okay. All right. Before I ask any other personal question again, let's look at, I think, Gloria, can you unmute your mic and ask your question? Is Gloria still? She actually asked, she asked 2 questions. One was about digitalization of patient records. How can we use this AI to start digitalizing patient records during medical visit in low, medium income countries, making sure that records are stored in a database and can be accessed digitally by any practitioner? And go ahead, Natira.
So, I mean, in an ideal world, I think that would be a great initiative.
You didn't confirm.
Sorry?
No, go ahead, please. Someone is...
We're going to have that meeting. I don't know why he's changing it to 30 minutes and why you are...
Patrick, can you mute yourself?
Patrick.
Yes, okay.
Yeah, go ahead, please.
Yes, I think the important issue there is the ethical considerations with regards to how the AI will interact with personal information. And it needs to be thoroughly looked at as to what would be the guardrails that we put in place to ensure that the AI is not using personal information from one patient to the next, because it's interacting with the information and it's not really having a ethical consideration, because it's just a machine. So I think it's something that needs to be explored, but very, very, a lot of things to consider.
Yeah, thank you. I think one thing to really consider is data protection, which is really key. And secondly, I think just as we're talking about sustainability here, for it to work, it's not just about buying a computer and trying to have an internet work on the spot, and then you say 2 people are using it. Yeah, it's also because the organization of the health system and how that can be channeled, within a service overall, also have a role to play. If it's in a health system where things are not really much digitalized or people are not really computer friendly, it might likely have a big issue as well. One question I think was still from Gloria was, has PAC at least over the years, have we evaluated to see that it has improved on overall patient waiting time? Is that one of the, for instance, we're looking at some of the benefit. I don't know whether this has been considered. Our question was, let me look. Gloria. Okay, yeah. Does PAC aim at improving long waiting time for patients to access healthcare, especially in Africa, where some patients have long wait time for medical procedure due to no practitioner material to facilitate procedures?
That isn't something I believe we've specifically evaluated. I know that initially when PAC gets implemented, staff will complain that it takes them longer to see the patients. And the Ministry of Health in Ethiopia conducted a small study to evaluate whether that in fact was the case. And they found that it did initially increase the time to even see the patient, because what PAC does is it kind of takes you very systematically through all the items that need to be checked off in a consultation. And so the training has attempted to support trying to get the clinician to prioritize how to navigate their way through a 5-minute consultation while using PAC. I mean, the aim, even though we don't know if it increases patient waiting time or not, the aim is that it is more efficient eventually, so that patients are visiting the health facilities less frequently ultimately because they're better controlled. So no, that would be something that we should look at. Certainly in Ethiopia and Nigeria, the health facility staff made an effort to educate the patients in the waiting rooms and within their local communities that this was a new initiative that was there to implement policy, and they required the community support and engagement for its implementation, which seemed to be quite an effective way to get the health workers to use the tool, because now they had the endorsement from the community. But no,
Yeah.
Times well look out for that one.
Yeah, thank you. I think even though perhaps that might not have been particularly evaluated, but I think PAC definitely must have had a positive impact on the overall quality of care that patients receive, which is, I think, that is more valuable compared to you not waiting and having kind of a care that is substandard or suboptimal. I think that is likely to be the case. But adjusting the healthcare processes might take time, and that might lead to that particular output not being able to show that outcome of waiting time not being able to show as if it's improved. Yeah, go ahead, Ruth.
Sorry, the multimorbidity study I referred to in the presentation was looking at this issue slightly differently to try and see how to task shift some of the care necessary for patients with multiple long-term conditions, so that they weren't waiting for a long time and then seeing their practitioner and having to get everything sorted out there, but along the way getting their screening or monitoring or whatever else they needed, and using community resources to deliver medication, etc., so that the time spent in the health facility was minimized. So that is something that the multimorbidity study is looking to evaluate at the moment. Yes, don't know the answer yet.
All right. Thank you so much. Yeah, I think we are 15 minutes after the hour, so I want to take this time to really say thank you so much. These questions, if you have further questions, please, you're a GENE member, you can drop it on the GENE WhatsApp group. If you really particularly have something that you want to discuss, you can as well contact me on this email, or Ruth. You can Google her name and you will definitely see her work. Thank you so much for the time. Thank you for your presentation, and we can make Africa great too again by contributing towards it in this way. Thank you, everyone. Thank you.
Thank you. Thank you,
everyone.
For the opportunity.
Thank you, everyone.
Bye-bye.
Bye. Thanks.